Hello everyone, good morning, and thank you very much Vanessa for the lovely introduction, and thank you to DRNI for the invitation to come and speak at this inaugural North-South Research Symposium. And actually this is a really good example of a cross-border trial that I am going to talk about today. It's called Brain Diabetes, and it was a really great collaboration between Queen's University, University of Galway, ATU Sligo, Trinity College Dublin, Western Trust, and also Sligo University Hospital. And it was funded under a European programme under the Cross-Border Healthcare Intervention Trials in Ireland Network. So Peter Passmore from Queen's was the PI for the project. So I am really presenting on behalf of a huge team, so no pressure. But what I'm going to talk about today is really the evaluation. The purpose of Brain Diabetes was really to evaluate a culturally tailored lifestyle intervention for older people with type 2 diabetes who were living in border regions. And I'll talk about how, sort of background, how we developed the project, talking about the translational adaptations and decision making around that, and then give you some of the findings from the feasibility trial. But I think also to point out as we begin is that we had huge challenges, not least the COVID-19 pandemic. So I'll be talking about some of that as well. Okay, so the inspiration for Brain Diabetes was from the FINGER trial. So it was conducted in Finland, and it was really a landmark, large-scale randomized controlled trial that demonstrated that lifestyle intervention, albeit really resource-intensive, could actually be protective for brain health and cognitive decline. So this trial was conducted in Finland, and they recruited over 1,200 older adults who lived in the community. They were cognitively healthy, had no impairment, but they had increased risk of dementia. And they were randomized then to the multi-component or multi-domain intervention, or a standard control that received general health advice over 2 years. And you can see here the intervention, so finger, but it's actually including the thumb as well. So we've got, it was consisted of like personalised advice to adopt a healthy diet based on the Finnish dietary guidelines. The exercise component was a group and individual sort of based program, structured exercise classes to adopt aerobic and resistance exercises. There was computerized cognitive training for mental stimulation, and it also optimized social engagement and cardiovascular risk through modification of risk factors. So in terms of just the trial findings, after 2 years, the intervention is in the orange, the controls in the blue, but really what it demonstrated is that there was a intervention effect, a positive effect on cognitive performance across multiple domains, global cognition, executive functioning, some memory tasks, and also processing speed. And what they found was that the control group had 30% increased risk of cognitive decline relative to the intervention group. Also, they found broader benefits of the intervention for physical functional decline, and also cardiometabolic health, and just better health-related quality of life. So it had those broader health benefits that we would be interested in ageing research. So one of the key questions coming out of that trial is how well that the results can be replicated in other populations. So Finland, they have the type of population that was recruited were actually very highly educated. The intervention itself was delivered by health professionals using individual sessions and also group classes over 2 years. It was very, very resource intensive. So there are now a network of trials in the Worldwide Fingers Network. I think there's over 30 countries participating in this network, and they're testing different adaptations of the finger model across different settings and populations with more diverse risk profiles. And really the questions that they want to answer is, can these results be replicated in other populations and in other settings? What are the necessary and optimal doses to include in these multi-domain interventions? And can they be delivered using more scalable and low-cost approaches? So Brain Diabetes Ireland was part of this global network, but we uniquely focused on people living with type 2 diabetes. And so Bernadette mentioned about diabetes coming out as one of the major risk factors in the NICOLA cohort, and actually it is an established risk factor for dementia in later life. It's associated with about 2 to 4 times increased dementia risk. And it is a big problem in Ireland. It's estimated around 250,000 people are living with type 2 diabetes in Ireland, but there are also many more in the community who live with diabetes that's on diagnosis. Data from the TILDA study, which is the population study in the south of Ireland, estimated that about 1 in 10 diabetes cases are actually undiagnosed amongst those 50 years and over. So it's a big problem. Also, in parallel, we know that there are sort of health disparities, particularly people who live in rural areas, and they may be more likely to experience greater health inequalities, less access to preventative services, potentially transport barriers, and also may experience more social isolation than those who live in urban areas. So we focused on people with type 2 diabetes really as a risk factor for dementia in later life, but also as a population who are underserved. So brain diabetes was actually delivered in 2 phases. So we had phase 1, where we really wanted to think about how do we adapt this multi-domain intervention for our target population. And in that respect, we did literature review, looked at the latest findings in the dementia literature, and also we did some qualitative work with people with type 2 diabetes living in selected rural regions. And those were through focus group discussions. We wanted really to learn a bit more in depth about some of the potential barriers people with lived experience might have in adopting some of the components of this multi-domain lifestyle intervention. And we were particularly interested in the diet, the exercise, and the cognitive training. So I'm just going to give an overview of some of the findings, but if you're interested, the paper has been published and it gives more in-depth analyses. So I'll just talk through some of the barriers that we find in each case. I'm not going to read out everything on the slide, but we did see multiple barriers to adopting a brain healthy diet in people living with type 2 diabetes in rural communities. So some of the barriers were things that we already know, things like cost, for example, cost of particularly some of the healthier components like fish, olive oil, berries. So there's a quote there. For some people, cost is a factor. A punnet of strawberries, punnet of raspberries, that's £10 gone virtually. And then also, old people, we have to think about their broader social circumstances. So some of our participants actually lived alone, and there's a quote there, "I'm on my own, my husband's dead. By the time you cook something, you just have no interest in it. It's just getting the portions right." So there's lots of factors there that could actually potentially influence food choices. We also saw strong contextual factors that could be influencing food behaviours in rural communities. And in terms of the social function of food, that was quite interesting. But there was some discussions around how sort of indulgent sweet foods like biscuits and cakes are often served with tea as you sort of a welcome tradition into the Irish household. We've all been there. And it's a bit rude to say no, even if you have diabetes. So that is one aspect that was brought up. Another one is around the farming community. If we're thinking about rural areas, farming is really the backbone of our rural communities, and foods that might be more difficult to reduce in rural Ireland were the certain food items like butter, cheese, red meat, that might be considered to be brain unhealthy, but actually form a very strong cultural component in those communities, and they may be difficult for people to sort of change or give up completely. So we need to think about all of those factors in the individualised advice that we provide. Barriers to exercise then. Some of the barriers that we identified were largely in relation to beliefs about exercise, and also the perceived self-efficacy or a confidence to perform exercises. And then there were more external factors like accessibility factors, like distance and time. So most of our participants actually in the focus groups enjoyed walking, and they felt that that's where they got their main form of exercise from, and they felt that that was sufficient for their exercise level. We also had several men in our focus groups who actually felt that their occupational activity was more than sufficient for their physical exercise. So there's a quote there. I think you get plenty of exercise around the farm. I wouldn't be interested at all. When I get home at night from milking cows, I like to sit down. So not really interested in taking up an exercise program because they feel their occupational activity is more than sufficient. And then some of the barriers around self-efficacy were largely to do with chronic pain or some of the comorbidities that are associated with older age, but also with diabetes-related complications like poor vision and circulation, in addition to breathing problems and arthritis. And then people are busy, so it was the external factors like accessibility, how far away the program, how far distance did they need to travel, weather conditions, timing of the classes, all of those factors were brought up as potential barriers. So for us, the learning experience for that was really thinking about a flexible program that really combines the exercise components, but really from group-based classes through to home exercises, and building in walking exercise as well into that. So that was the exercise, and then we also explored the computerized cognitive training in the focus groups. And most of the barriers to that were in relation to accessibility. So limited broadband access, which we didn't fully appreciate, but it is a huge factor in rural communities, and also even computer literacy in this age group. Again, around the self-efficacy to perform the computer programs, and also motivation to take part. So you can see there that the motivation was particularly, it was sort of a polarizing factor. There were people in the focus groups that really had no motivation to take up computerized training. I've no training for it, no knowledge of it. I just never used it in my work. I'm a farmer, a cattle dealer. I wouldn't be into computers anyway, no interest at all. Daughter does that all for me. So some of the facilitators that came up as potential supports for the cognitive training were providing, an onboarding training session with participants, having a dedicated person where they could speak to them about the computerized cognitive training, and also ensuring that there's flexibility in how the training can take place on a device. So that we looked at all the focus group informations, the literature, what was coming out of the literature, and also some pragmatic decisions about what we could feasibly do. And we made some decisions in terms of the diet element. So it was going to be based on individual and group dietary counselling to meet Mind Diet, which is a sort of healthy brain pattern. But we were able to really easily culturally tailor that for our population food preferences, and it was suitable also for people with type 2 diabetes. Physical activity, I mentioned, we wanted to have structured and supervised group exercise classes, minimum of twice a week, and we exploited an existing commercial program called XWell, which is a group-based program, and has really nice results for older people, particularly those with chronic diseases or comorbidities, increasing cardiovascular fitness and also confidence in performing behaviours. So we were able to use the XWell programme, and that combined the aerobic and strengthening exercises. We also promoted walking, and we also created some home-based exercises as well. The cognitive training we were delivering on a platform called Brain HQ, and that was a series of games that built up over time to improve information processing, learning, memory, and executive functioning. So the protocol, what we expected was that participants would perform these computerized games at least 3 times per week at home. And then we made them available on a range of devices. However, internet access was required, so we actually had to build that into the eligibility criteria for brain diabetes trial. And then the cardiometabolic monitoring was to be done face-to-face with the nurse when the participants come along to their study visits at 4, 6, and 12 months. So it was a 12-month trial that we were anticipating at that particular time. So moving on to phase 2, which was actually the trial itself, and this was a pilot study. So we wanted to test the feasibility of this adapted model in our target population group. And so our outcomes were really around, can we recruit them? Can we retain them into the study? How well can they adhere to the intervention components? And are there any behavioural changes in response to the multi-domain intervention? And we also collected some clinical outcomes, really to explore any potential signals of intervention effects on these clinical outcomes. Cognition, metabolic health, and quality of life is what we were interested in. So we were just about to recruit in May 2020, and that almost perfectly aligned with the global COVID-19 pandemic, which, there was so much work getting up to this stage of actually starting the study. So we really had to quickly pivot and think about what we were going to do. So the plan was to recruit across 2 sites, Sligo, Leitrim, Fermanagh, Tyrone, either side of the border. We wanted to recruit 140 people who were living with type 2 diabetes, had no cognitive impairment, and we were going to randomise them, similar to the finger, one into the intervention or the control group, and our idea was that that would be followed up until 12 months. But most of our study nurses on the trial actually were redeployed then to deliver clinical services. We also had to think about our target population group, people with type 2 diabetes, who were considered a very vulnerable population and were socially isolating at that particular time. So we made a number of decisions really to move all of the intervention components to be delivered remotely at an individual level. So we completely removed all the group-based activities from the protocol, and that effectively removing the social support elements as well. We retained our face-to-face outcome assessments and the cardiometabolic monitoring by the study nurses at the study visits, but we had a lot of sort of risk assessment done, and we adhered to the COVID-19 advice at that particular time. But really, overall, it really delayed our recruitment by about 18 months, and that had a huge impact on what we could do. So we had to abandon our follow-up to 12 months, and we reduced that down to 6 months just to enable us to complete the trial. We were actually we only had 7 months to recruit in total, and we recruited 79 people who met the eligibility criteria, and they were randomised into the intervention and control group. You can see 39 in the intervention, 40 in the control, and then by the end of 6 months we had about 15 people who withdrew from the study, so our attrition rate was 19%. We were really delighted with those findings, and actually we met most of our feasibility criteria. We didn't meet the overall target sample size, but actually our monthly recruitment rate was much greater than what we anticipated at the outset. So we recruited about 6 to 7 participants per month. Our retention rate was 81%. We had set all a priori criteria around this. And also we had less than 20% between group difference in retention, which is important as well. And the reasons for withdrawal from the trial were just lack of time, illness, COVID actually was a big problem, also change in personal circumstances, so some people changed location. Who took part in the study? Generally people who were in their 60s with type 2 diabetes, mostly male. They were all BMI of greater than 30, so living with obesity, living with central obesity, but actually quite metabolic, in terms of the parameters were quite good. Their HbA1c was a sort of, borderline normal, and they're cognitively healthy. They had a moderate adherence to a healthy diet, and also sort of physically quite active as well, the high step count at baseline. And the groups were quite well balanced at baseline as well. So this slide just shows the participation with the intervention component session. So it's just, we wanted to compare with some of the other finger studies that were out there. So we wanted to ensure that people attended at least 50% of their scheduled appointments for each of the intervention components. And we saw highest compliance with the diet and the cardiometabolic monitoring. And actually most of the participants attended their over 50% of their scheduled exercise sessions as well with our exercise instructor. The main component that was problematic was the computerized cognitive training. So around 50% of the participants did not complete, they completed less than 50% of the scheduled cognitive training sessions. Okay, so moving on to some of the results then. This just shows some of the changes in the Mind Diet score and the step count in response to the intervention over time. So this is the change, and this is the month 4, month 6. Here we have the control group in orange and the intervention in blue. And what we saw was that there was a significant improvement in diet quality towards the Mind Diet in response to the intervention. It increased Mind Diet score by an average of 3 points. And ours, that was greater than our target 2-point increase we had set. In terms of step count, there was an increase in step count in the intervention, but there was no significant difference between the two groups. But our intervention participants managed to achieve around 9,000 steps a day. In terms of cognitive performance, we used a similar neurocognitive test battery to the original finger trial. Obviously, it was only a 6-month study, so we actually didn't see any impact of the intervention in global cognition. This is memory score, and this is executive functioning score. So we didn't see any impact of the intervention on cognition. We weren't, powered to detect changes in the clinical measures, but we did see some interesting signals that the intervention had some impacts on metabolic health parameters. So there was some reductions moving towards reduced BMI and HbA1c in the intervention, but it didn't reach significance compared to the controls. These are adjusted by age, sex, and the study site. But we did see significant improvements really in triglyceride levels in response to the intervention. We also saw, interestingly, improvements in health-related quality of life across both physical and mental health domains in response to the intervention over this short time frame. At the end, we conducted interviews with our study participants, and there was really a great sort of acceptability for brain diabetes. In fact, all of the participants said that they would recommend the program to friends and family. And they really valued the support that was provided by the nutritionist and the exercise instructor. I think that it was really to do with that personalised tailoring of advice and support. And they felt that that was really helpful to motivate their behaviour change. We did provide, written educational materials as well, and they were considered helpful, but I think it was more of an adjunct to the personalisation and tailoring from the study staff. Some of our participants would have preferred more peer support, but we weren't able to deliver that. And as I mentioned earlier, around 50% of the sample didn't really do the computerised cognitive training. So some of the quotes here was, "Oh, the computer end of it, complete disaster." But of course, I'm not computer literate, so that didn't help either. And then tedious, I have to say tedious is the one word I would describe it as. It was almost not training my brain so much as training my peripheral vision, which is the games that are included in this programme. So just to summarise, despite the significant setbacks that we had with the global COVID-19 pandemic, we actually proved that brain diabetes trial was feasible in terms of being able to recruit and retain older adults with type 2 diabetes living in the rural border regions. A major strength was really our team, and we just proved to be quite cohesive and agile in making these decisions. And the decisions actually to deliver the intervention components remotely and implement those safely during the pandemic were actually shown to be feasible for lifestyle behaviour change. And I think actually that could have potential even more promising impact for scalability in terms of cost effectiveness. We didn't see any effects on 6-month change in cognitive performance, but we saw small indicative impacts on improved metabolic health and quality of life. And participants enjoyed taking part in it. It was really well received, despite the remote delivery and the lack of social support. For us as a group, we really do need to think about how we facilitate cognitive stimulation within the programme, and thinking about ways to deliver that, particularly in rural communities where we really do have to think about the digital exclusion aspects as well. So I just want to finish by acknowledging the whole team, the brain diabetes team. They're all listed there, particularly our PI, Professor Peter Passmore, who led the way, and all of the meetings that we had online and in person with our masks on. So it was a huge study. It was a pleasure to be involved, and just to thank our participants, PPI members, our funders, and also our external